So this video snippet addresses risks that are only semi-specific to the thorax. These risks obviously occur in other places, but they have more potency in the thorax. But please understand that this is not a comprehensive list of all manipulative contraindications, but those that are more related to the thorax, more potentially damaging the thorax than other areas. Okay, so the risks are basically misdiagnosis and, of course, misdiagnoses, bone fragility, neoplastic disease, asymptomatic myelopathy, radiculopathy, and bleeding disorders. All of these have particular potency when it comes to the thoracic spine, and we'll explain why in a moment. Okay, so misdiagnosis and, of course, misdiagnoses. Cardiac problems are the obvious one to consider here, simply because the outcome of these can be fatal. We talked about the cardiac decision rule, cardiac equivalent, and so on. Interestingly enough, though, there is a rule called the Vancouver chest pain rule. It's got very high sensitivity and moderate below moderate specificity, but that's fine. This is a screening out test. So the sensitivity was 95.1, the specificity was 56.3, gave you a negative likelihood ratio, which is what we're interested in, 0.02. And the negative prediction value was about 98%. So this is not bad, and there's really only two parts of this. You can certainly go online, look at the Vancouver chest pain rule, and it will take you to a device, a button device, where you can just punch in the positives and negatives of this. And it's interesting, but if you punch in age over 50 and also punch in negative palpation, what the rule tells you is do a proper chest cardiac exam on these patients. So if those two things are coming up, it's enough for you to fire it back either to the emergency room or back to the physician, whichever you think is reasonable, probably the emergency room. Reflux is basically going to be sent to the physicians, because the patient really knows what it is. It's a sharp, acidy pain with an acid taste. They pretty much know what's going on. So the chances are you're not going to see it. But this will give them substernal, sharp, stingy pain. Lung problems tend not to be particularly painful, but there is a persistent cough and shortness of breath. And again, this is going to be an older patient. If this is lung cancer, they're going to be over 50 again. But it's worth asking for these, not because they're going to present with this. They're going to be present with something else, but they may have this, and it's worthwhile asking as a routine exam to basically make sure that you're not missing this. Pleurodenia. This can be traumatic or it can be non-traumatic. It's a very sharp musculoskeletal type pain, and it occurs with movements. Now, if this is in the upper part of the lung, then arm and neck movements may kick it off. If it's lower, then it's going to be trunk rotation. But again, negative palpation is going to be the key to this. There's nothing showing. Stress fractures or muscle tears. Usually it's caused by prolonged bouts of coughing, a prolonged episode of coughing or sneezing. And there's a sudden onset of sharper pain, although there may be a build-up to this as the muscle is getting stressed out and the rib is becoming a little bit more stressed out. But the onset is usually quite sudden. And the kicker here is going to be tender over the rib or over the muscle, depending on which is in trouble. Pathological fractures. The obvious cause of this is osteoporosis for the most part. So you're going to have a sudden onset of their severest pain. They're going to be amenopausal. Even young girls now, we're looking at 15, 16-year-olds are either having trouble with nutrition or they're over-exercising, they shut their periods down, and this follows. They look frail. They may have a history of fractures, obviously. The rib now is tender if it is a rib, or if it's a vertebra, then it's going to be a central line pain, a midline pain with tenderness over the midline. If you're very careful, you can test rib springiness, and that's going to be decreased with osteoporosis, as well as with some of the systemic conditions. There may or may not be neurological deficits, depending on whether the fracture has involved either the peripheral nerve or the spinal cord. Systemic diseases, big one is obviously going to be ankylosing spondylitis. There may be general malaise, other joint involvement, enthesitis, gut issues, iritis if this is part of a reactive arthritis. And again, the rib expansion may be decreased and there may be a decrease in rib springiness.
Bone fragility, mostly caused by osteoporosis, of course, is a particular problem in the thorax because of the ribs. These are small bones and they tend to break anyway. And the fact that when they get osteoporotic, they lose their springiness doesn't help much neither. So these tend to be particularly vulnerable to forces both direct to the area, also compression from front to back. So it's well worthwhile understanding what osteoporosis can look like in a patient. So you're looking for geriatric and frail people. Not all geriatrics are particularly osteoporotic, but when they look frail and they are of an age 65 and over, then you've got really quite a high risk of doing some damage through here. Now, it's not just manipulation. In fact, you have really a contraindication at the moment of ages. So nobody's expecting you to manipulate a patient who's over 65, probably 55 in fact, initially, but later on you're going to be doing so. And on top of that, any physical force applied to an osteoporotic rib cage can fracture ribs, so be careful of them. Young and amenorrheic. Now your problem is finding out if they are amenorrheic or not. But malnourished children, 16, 17, younger and so on, or a very extreme exercise are likely to be amenorrheic. So it's well worth asking them if they're still having regular periods. And if so, when did they stop? If this has been within a few months, then they're probably okay. But if this has been going on for some time, there's a really good chance that they are osteoporotic. And of course, they'll never get tested. Nobody expects it. They certainly don't expect to be osteoporotic at that age. You're looking for fractures after insufficient fall. You should be able to fall, standing fall, and not break anything. And one of the most common osteoporotic fractures in the postmenopausal is a Colles fracture, because they'll fall on the outstretched hand, which should be able to withstand that, and then they'll fracture the radius. You rarely see those in men, and this is why, because these people are osteoporotic. Or stress fractures after insufficient stress. Now, what's sufficient, what's insufficient? It's a bit of an issue. But insufficient stress externally can look insufficient, but if there's another problem within the patient's body that doesn't allow compensatory movements to occur, then what would normally be insufficient stress is enough to fracture an otherwise healthy bone over time. But you don't know that. It needs to be tested out. So you expect stress fractures after prolonged periods of exercises and over many, many months or years. But if these people are not doing that much exercise, it's not reasonable to put this down to insufficient stress. So there's either a pathology in the bone or there is something else stressing out the bone in addition to the external stress they're applying.
Okay, neoplastic disease. It's worth noting that 60 to 70% of all secondary tumours in the spine are found in the thoracic spine, particularly in the lower part. Of these, 90% are in the musculoskeletal system rather than the neurological system. Ages over 50. The average age for getting this is around about 60. The pain is central, obviously. There may or may not be subtle neuropathic signs and symptoms. We're looking at sensory loss and motor loss, and this takes some very careful testing apparently. The onset tends to be sudden, the pain.
Okay, now I know we spoke about this before a few times, one on the video on discogenic pain, and also when we was talking about disc herniation, misdiagnosis earlier. but it's worth repeating again. 40% of disc herniations are asymptomatic, but may well require treatment. Now, the only way you know these things are there and actually disc herniations is to look at the neurological component of this. So this is almost an incidental finding. They're probably coming in for something you're going to treat, something standard, but if you look at the spinal cord or the spinal nerve root and its extensions, you may well find something, and it's worthwhile doing this. What you don't want to do is manipulate a disc herniation, for example, and make that worse by accident. Don't really want to do it on purpose neither, but you certainly don't want to do it because you haven't looked. Also, don't forget these asymptomatic myelopathies and radiculopathies can be caused by Neoplastic Disease. So look for them. As far as the spinal cord is concerned, the standard stuff: Babinski, clonus, spasticity, hypertonicity, hyperreflexia. Look at Beaver's test if you've got weakness, sensory loss, bladder, bowel dysfunctions. Spasticity isn't usually taught very well or taught at all, but it's reasonably easy to test. You just hold the leg up off the bed a little bit, bend the knee, and then let the knee drop down. And you may well see it catch. So you're holding the foot up, just let the knee drop, and you'll see it catch if it's present. As far as a radiculopathy is concerned, you can test intercostal weakness and hypotonicity rather by putting your fingers in between the ribs. You do the same thing for the spinal cord, but it's much more difficult to deal with. But you do the same thing, but now you're looking at it to be difficult again. Whereas with hypotonicity, you're looking for it easier to go in. You're then going to take a deep breath in, hold it, and then you try and push your fingers in again. And whereas hypotonic, if you picked it up, will also be easier to push in. Beaver's test if it's a lower thoracic problem, and the same for abdominal cutaneous reflexia, hyporeflexia. These are not common, but they're worth looking for, and you do this enough times and it won't take any time at all to do this. As you can see from this list, these risks are not going to become manifest very often, but there's a good chance at some point in your career, one or two of these will come through your clinic, and it's well worth you knowing how to look for them. In addition, you will end up being basically your clinic or your organisation's expert on manual therapy. So you're going to see patients that are not quite normal because you're going to be seeing these as consults from other therapists, and these may then turn up much more frequently in those cases because there's something different about them. So it really is your responsibility to know how to do these tests and how to do them well and quickly. So take care, everybody, and I'll be talking to you again soon. Bye-bye.